Welcome from the Royal Society of Canada to the webinar session on Investing in Canada's Nursing Workforce Post-Pandemic, a Call to Action. I'm delighted to be the moderator for the session today. I am Tara Sampali, Senior Scientific Director, Nova Scotia Health, and I am the co-chair for the review that is being presented today. The Royal Society of Canada is Canada's national academy and recognizes Canada's leading intellectuals, scholars, researchers, and artists, and mobilizes them in open discussion and debate to advance knowledge, encourage integrated interdisciplinary understandings, and address issues that are critical to Canada and Canadians. And I'd like to acknowledge that RSC is hosting this event, and their offices are located on the traditional, unceded territory of the Algonquin Nation. From coast to coast to coast, we are grateful to acknowledge the ancestral and unceded territory of the Inuit, First Nations, and the Métis peoples, and recognize the dozens of languages and cultures Indigenous peoples have brought that enrich what many call Turtle Island. This event is being recorded and will be posted on the RSC website following the event. Today's event explores themes of the RSC policy briefing on investing in Canada's nursing workforce post-pandemic, a call to action. This review aims to identify and better understand factors that have contributed to long-standing nursing shortages in Canada and worldwide, and to develop recommendations and key actions to aid in preventing further attrition of Canadian nurses from point-of-care roles in the wake of the COVID-19 crisis. I'm so delighted to let you know that we have a fantastic panel of experts who will bring their expertise at many levels, from provincial, national, international. We have Dr. Carrie McCarthy, who's a technical officer working in the Health Workforce Department in the World Health Organization. Welcome, Carrie. We have Linda Silas, who's the President, Canadian Federation of Nurses Unions. Welcome, Linda. And we have Dr. Gail Tomlin-Murphy, who is the VP Research, Innovation and Discovery, and the Chief Nurse Executive at Nova Scotia Health, and also the chair for the review that will be presented today. So to start with, we'll present the findings from this review, which is really what we're showcasing today. And following that, you'll hear key perspectives from Dr. Gail Tomlin-Murphy, who's the chair of this review. You'll also hear from Linda Silas, who was a key member of this review, and she'll bring her perspectives from a national level. And we also have Dr. Carrie McCarthy, who will bring the international perspectives and some of the great work she has led as well. Following this, we will turn to a group discussion and pose a question to this amazing panelists so that we can hear from them. And I would definitely urge you all to take the opportunity to speak to these wonderful panel experts and pose your questions at the end of it. And to participate in the Q&A, you need to submit your question via the Q&A feature at the bottom of your screen. So, and should people wish to join the conversation online or to learn more about the RSC events, policy briefings, you can follow RSC on Twitter at RSC, the Academies. The handle has also been included on the PowerPoint slides. And I'm thinking, without further delay, we get started with the main event. So to start us off, I would welcome Dr. Gail Tomlin-Murphy to talk to us about this overview, and I'll join you, Gail, in presenting some learnings from this.
Thank you. Thank you so much. And thank you to all of you for joining us today. And thank you, Dr. Sampali, for the leadership that you've brought on many fronts. And a special thank you as well to the Royal Society of Canada to highlight this very, very important call to action. We're truly grateful. I am also very grateful to the experts that worked at this across the country. And many of you are participating today. And this work is only a result of the work that we've done together. So I would like to, at this point, it is my pleasure to be here with you, of course, and to acknowledge, in addition to what you have, Tara, I'm speaking to you here from Mi'kmaq, and this is the ancestral as well as the unceded territory, the Mi'kmaq people. We're all treaty people. I would like to say that I'm a nurse. And first, I'm a nurse. My background is critical care nursing, and I've had quite a career having the opportunity to study nursing, as well as to move forward, to come up with recommendations, many reports. You know what? Many of those reports have sat on shelves. And I believe very strongly, as do the group of experts and those of you who have been engaged in this and are living every day the privilege of being a nurse, and also the struggles and the challenges that are facing us every day. It's together that these recommendations are going to make a difference. So it's not new. And I'm so pleased to have Carrie here today as well, because when we think about healthcare workers, the highest proportion of healthcare workers are nurses. And we know that we've played an essential role in all of this. The ongoing efforts during COVID-19, we've also dealt with many challenges prior to COVID-19. We're learning from it. And as we face things today in terms of the recommendations, let's find ways that we can move them forward. It's shone the light. We've heard that term a lot, but it has really shone the light on where the gaps are in today's healthcare system and across the globe, where the gaps actually are, and how fragile the system is, and how fragile nursing is. And so together, let's move forward and better understand these issues. They're longstanding. I'm an older person now, and I've been facing them most of my career. So Dr. Simpali, if you could just go over and give, please, some of the highlights of the report, that would be fantastic. Over to you, Tara.
Thank you so much, Gail. And thanks for sharing that context. And, for us, this opportunity did come, and it's been fantastic. Like Gail said, these are not new issues or considerations, but the pandemic has really made it an important consideration for us to look at the situation of the workforce in many ways, and the nursing workforce in particular. So the Royal Society of Canada really brought us this opportunity, as they have led many policy briefs and issues through the pandemic, they bring researchers and others to really think about some key policy considerations and actions. So this was really our opportunity to come together, and we came together and with a great group of people to really support it. And one of the things we wanted to look at is, as Gail mentioned, these are all not new considerations or issues that we're looking at it. The pandemic has definitely brought it forward into our awareness. So as we look at what is in the evidence, and over a number of years, there are so many considerations that have come to the forefront. For example, education, designing competency-based curricula, aligning it with population health needs, ensuring that we have faculty who are trained in the best education models, technologies, and COVID definitely brought technology in a massive way for us. Also need to strengthen development educational programs that will help expand nursing competencies in primary care and many other care areas. We also know that nurses need to feel valued. We need to ensure that their expertise are brought forward. So thinking about optimization in many ways, but really to bring that value forward, thinking about the team-based care delivery, how can all team members be part of the process, and how do nurses also play a key role within team environments, and making workplaces safe and supportive. And then we think about employment in many ways. How do we really help people feel the satisfaction of providing the care, bringing the best patient care forward? And these are some key things that nurses have told over the years. And these feed into that kind of the retention, recruitment kind of process, where these become key considerations. And leadership. Nurses are leaders, and they're working in many different ways to support. And how do we ensure that people are engaged, including people working in care areas? How can we bring them? And so when you think about all this, and it is no surprise that, we are thinking about it from the pandemic to see how all of these have really become much bigger, greater, and we see nurses leaving the organization. So we are grateful when Royal Society of Canada brought this opportunity to Gail as the chair, and really thinking about bringing that key expertise and trying to understand what is this opportunity, where are we now, what can we understand from what has already happened and what we know from many reports that have come together, and how can we bring something that feeds into action. We need to do something about it now. It's a crisis situation. How can we do that? I'd like to take the opportunity to thank several key expert leaders, nursing leaders from across Canada that came together to offer their guidance and support to help us through this review and coming up with recommendations and key actions. I'd also like to thank an incredible team from Nova Scotia that came together to do the review, working with the expert team. And they did it in such a fast pace. I say that we started, fall of 2021, and by December we were done. And by the time the publication happened, we went and gathered additional information to make it as current as possible, recognizing how fast we're moving. But I'd like to thank, and I also want to thank Saskatchewan, some of the leaders that came forward to provide, and other jurisdictional leaders who offered guidance and provided relevant data to guide the review. So we did take from multiple sources because we knew that there's considerable evidence in the pre-COVID and during COVID. So we didn't want to duplicate, but we wanted to look at it in a way that to say, what is consistent information, kind of the recommendations that have come forward that may not have been addressed effectively, and how can we really build on that? But essentially to bring those, nursing perspectives and pick up on surveys and others that have brought these forward, and how can we bring it towards a recommendation key action point. As we mentioned, we really wanted to look at what is evidence already telling us a number of times in many different types of reports, look at different jurisdictions and what they have been doing to date. So we really had a lot of documents reviewed, but very intentionally. We wanted to look at trends and themes. We wanted to look at what's consistent. We wanted to look at jurisdictions and what they're doing. We also wanted to look at participants, the nurses who could give us their perspective. So we did engage from Nova Scotia and Saskatchewan, and that was a very important opportunity within this. And our experts, they're all nurses and leading experts in the area in many different ways, and they brought their perspectives. So some of our findings are very consistent with all what is already there. First of all, the complexity of the patients has to be considered. There's changing demands for care. COVID-19 amplified this in many different ways. So given this, you have aging population, complex care needs, work-life balance became a priority and has shown up in many different reports. Equity in pay, we have nurses who are migrating within care areas. So how do we do that? Also leaving the organization. So lack of incentives, lack of supports for professional development. How can we improve that? Training, supervision, mentorship, looking at from an education perspective, training perspective, what can that look like? So what is clear definitely at the end of our findings was these are all not new issues, not new issues, but how do we really build on that and come up with some recommendation that will propel us towards action? So I'm going to present the 7 recommendations that came through this report, but Gail will then bring it together in the key actions that came forth. So first recommendation is develop a pan-Canadian strategy that can bring us sustained focus to strengthen retention and recruitment of nursing workforce. This has been key, that it's not only that we bring a strategy, but it has to be sustained. And so part of it is to have that strategy focus on the human resource strategy, looking at appointment of key nursing leadership role that can lead the development, operationalization, and evaluation of the strategy that go into place. Development of timely, comprehensive, and accessible nursing workforce data. This is critical to inform health human resource planning and decision-making. And identifying a team of diverse nurses with representation across all jurisdictions to play a key role in these activities. The second recommendation is really looking at the workload, staffing, and skills mix, and payment models. This is important. Thinking about flexibility in these models that are also required, and think about how we can become competitive across the country, but also internationally to ensure that there is equity for all of these. And a standing theme that we want to look more into has been about the EDI considerations through all this. Third recommendation is to implement systemic process beyond remuneration. This brings about valuing the nursing workforce, thinking about how we can really bring the critical representation we need in planning and decision-making tables, how we can demonstrate value in bringing those mentorship, professional development activities, and how do we really bring the EDI lens within this is going to be critical. Recommendation 4 is that we need to strengthen the voice of nurses. And this has to happen in many ways. And I know many jurisdictions are really thinking about it, but how do we make it practical? Not only we need voices at the federal table, we also need for this to go at the local levels, and there has to be a connection, but also we need to think about nurses in the care areas and how they can really support this. And we also have to think about how we include and initiate the conversations with our First Nations, Inuit, Métis, and other organizations, and thinking about the racial equity and justice to strengthen the voice of nursing. And recommendation 5 is to enhance authentic intersectoral partnerships. This is about working across the education, the health system, and other organizations, the unions and others, to ensure that the partnerships are really strong and we can build it together. And so this has been another important recommendation. And then, of course, to address equity, diversity, and inclusion, gender equity, systemic racism, and their impact on the workforce. So this needs its own space. So we have said that this is where we're going to move towards past this, because we feel like some of the topics and the recommendations are so critical that they need their own space and they need to be looked into further and build on the great work that's already happening. And the recommendation 7 is to implement safe workplace wellness strategies. It is no surprise that learning from the pandemic, this has become an important area. So COVID-19 has shown many vulnerabilities as we think about long-term care and other care areas that the Canadian health system has to really look at how it has affected nurses. And we need to implement strategies that really think about the safety and the wellness of our workforce. So this is our next recommendation. Gail, I'll go to you to speak to the key actions.
Thank you. Thanks so much, Tara. And one might say, we've heard some of these recommendations before. And so this group of experts move forward in terms of let's do it now. So I think you want to hear from Linda and Carrie and others today, and that's what we're going to do. We have had many tables, the key action around establishing a pan-Canadian nursing human resources strategy. The appetite is there, whether it's at federal, provincial, territorial tables, local community tables, that there definitely are people who are saying, we do need a strategy. We need to enact a strategy. We need to resource a strategy, and we need to evaluate the impact of strategy. And that's what many are doing, and we're going to hear that from the panel. Secondly, it's also engagement. We've talked a lot about empowering and bringing the voices of nurses to the table. We know firsthand that our nurses and healthcare providers who are providing care to patients and their families have the best ideas. They understand what needs to happen in terms of retention and recruitment. So that we need to establish a national nurse engagement task force to engage point of care nurses, something that might look different in communities and contexts, and because all of that matters, but to bring this task force together on a national level, there will be a lot of learnings, a lot of power, and a lot of influence. We have learned during COVID and even prior to that, the importance of our experts, many of our leaders, many of our nurses who have left, who have expertise, who would like to give back. We need to have a national coalition of nursing experts, and leaders, and they can guide what are those key questions that need to be asked? What are those rapid reviews? Where do we need those best practices? What do we need to better understand? And how do we then bring this to government decision makers in ways that make sense? And this is what needs this evidence, the real-time evidence, best practices needs to inform what the decisions that we're making. And lastly, to the most important point that Tara has outlined at this point, we need to be thinking differently. We need to have a lens of equity, diversity, and inclusiveness. And in this report and through experts, the key action that came forward is coming up with a distinction-based approach to align nursing services with United Nations Declaration on the Rights of Indigenous Peoples and Human Health Rights. These are the 4 key actions. We're going to hear more about some of these today. And also we look forward to ongoing conversations. And I'm going to watch my time and let Tara move us along.
Thank you so much, Gail. And that's a high level overview, and you have access to the report that the Royal Society of Canada has shared the link. So I hope many of you will get a chance to read that. Now we move to the panel section, and each of our panelists will bring their perspectives, which is really critical. And I'm going to start with Dr. Gail Tomlin-Murphy. So you are not only going to bring, feeding off the report and everything that we have developed, but also taking that provincial and the World Health Organization powerhouse that you bring so well, the international. So we'd like to hear from you as a start.
Okay, thanks. So we know I've had a privilege of working in the space in the local context, also across the country, and as director of the Collaborating Center in Health Workforce Planning and Research. So together, we've learned a lot. We need to invest, and that we are the foundation of our system, and that's pretty clear. And so as we move forward in terms of what are those top considerations, and you'll see this on the slide. And the rapid reviews that Tara talked about, whether the global, national, it doesn't matter where they are, that they talk a lot about these things on the slide before you. Access considerations, access to care, and access to care in different ways. And we've had a problem with that. We haven't measured it well, we don't understand it, but access is definitely at the front. The staff shortages, how long have we said these comes and goes of shortages and surpluses, and you know, we have been seeing this coming. This is not new. This is something that has continued to be a problem, plagued us, and it's exacerbated at different times. It comes forward. And so the overcrowding. So we come back to issues that have to do with access and flow. And where do they show up? And they show up in certain places. They show up, we might count ambulances and figure out how many are lined up and how many are inpatients. But the real problem here is that we haven't necessarily done and looked at full system integration with a hope to have people in their homes, to have them wherever they call their homes in where they should be living in and be involved in care. We've been, jurisdictional scans show the backlog of surgeries and the impact that COVID has had on care delivery. We didn't quite know what each wave was bringing. So we definitely have made some decisions around closing down services. But at the end of the day, when we think about nursing and nursing health human resources planning, we have to plan for pandemics. We have to plan for surges, but at the same time, service as usual. COVID-19. Of course, COVID is something we've all experienced together. It's exhausting. The thought of long COVID, as well as other pandemics coming, has been a huge issue. Highlighting also has been the access. And when we talk about access to rural, you know, we think about Canada and our geographical location. We often talk about urban delivery of care, but we know that we need to be thinking more broadly about chronic disease management. If we're keeping people home, what are different strategies, for instance, for rural care, rural delivery of care? And what impact we've read a lot about this, the impact of technology, efficiencies, enhancing productivity, and actually pushing that and including that in some of our planning is important. So if we go back to their solutions that we have seen, we've talked about, and we are actually executing. COVID-19 has helped us definitely to move into implementation and execution much quicker in partnerships, wrapping these around people. And so if we think about some of the examples around digital first, so access of care, so whether this is synchronous and asynchronous, that has propelled us forward in the world of virtual as well as digital solutions. And we'll never go back because we see the impact of these virtual solutions, for instance, on the care delivery. People capacity as being important. We've talked about retention and recruitment for a long time, but we are now seeing evidence of real plans, execution. In our province in particular, we have an Office of Retention and Recruitment whose job is, a deputy minister and staff, to actually work with the system as well as intersectorally with others to pay close attention to recruitment. And together, we are working on retention strategies as well. And so if we think about innovative models, we've gone from the days, and you know, I've been around all of us have been, where we fought against ourselves, nursing family, whether it's an LPN, as an MP, whether it's a family practice nurse, whether it's a registered nurse. But this has brought us to a point where we talk about innovative models of care, our formal and informal providers, in moving forward in ways that are actually wrapped around the needs of people and patients. And where people are. So this is incredibly important. And we've seen this in long-term care, in primary care, in acute care, in critical care, and most importantly as well, in partnerships with our community. So these real-time decision-making are incredibly important. The others, the learning health system, I'd like to just stop on for a second. We are in healthcare, we are the learning health system. So we have found ways and strategies through our scholars network, for instance, by bringing students in earlier to be involved in the delivery of care and paying them for that. We are seeing definitely the impact that this is having on learning health system. And what does it take? A recent jurisdictional scan that we did, and this rings home for most of us, in order to be innovative, there's some things that are really important, and we're here to think about those intersectoral partnerships across the system, community, as well as industry as full partners in healthcare delivery is important. We have to continue to be curious. We need to encourage people to be curious, and we have to support them when those ideas aren't taken forward in the way that they would like them. And we have to have that safe space for this to happen. We have to have visible leadership. Supportive is incredibly critical, and we need to engage our patients, our staff, and people who we haven't necessarily given voices to in the past. Together in Nova Scotia, we've done a few things around retention and recruitment. Early immersion of learners. We bring them, we hire them early, we promise them a position, and they come in to the healthcare system. We're doing this definitely in partnership. We're actually looking at ways as well to encourage teams to work well together, and not all teams work well together. So innovations around trying different models of care delivery has been really, really important. And in terms of transition to practice, my last comment will be, we've talked a lot about the importance of mentorship, and we have done mentorship on the shoulders of practicing nurses who are already tired and short. And so we're using different kinds of strategies to bring preceptors, our experienced nurses, as well as working really hard around optimization of scopes. And we're really pleased. RNs prescribing, NPs admitting, those types of things are really important. But I'm going to cut off there and pass over, Tara, please, to my colleagues.
Thank you so much, Gail. And it's really great to hear from the Nova Scotia experience and all of the things that are happening. I see some great questions coming, but Linda, over to you now to bring your national perspectives, and we're really looking forward to hearing from you.
Thank you so much, Tara. And first of all, thank you for the invitation. It's been a great experience working with Gail again. We go way back to the last big nursing shortage in 1997 with the Canadian Nursing Advisory, the sector studies, and then reports after reports. And it was really nice to meet you, Tara, virtually and work with you. I'm calling from the unceded territories of the Algonquin and Anishinaabe people, which is called Ottawa. Let's say we're a little bit in a mess. What I've seen over my 30 years of union work, I've never seen it so bad, and I've never seen a group of workers so angry, so tired, and not seeing the light at the end of the tunnel. So these reports and the work that we're all doing collectively has one goal, is to retain them and for them to see the light at the end of the tunnel. The nursing shortage is bad. It's kind of funny that I'm not the researcher on the panel and I'm giving you all the numbers, but Stat Canada says over 34,000 nursing vacant position. That's been an increase of 133% in the last 2 years. And what scares me the most is the 1 in 2 nurses wanting to switch jobs. And you might remember research projects of the past saying that it cost the system it used to cost $25,000 from one nurse to move from one unit to the other. And if he or she would move from an intensive care area, we were talking about $75,000. And 1 in 2 want to change jobs. And in Saskatchewan, it's 60% that wants to change job. And never mind the 20% that just want to leave healthcare, or the 20% that just wants to retire early. So we have to move on that. The working environment is, when I say I've never seen it as bad as that in 30 years, there's a reason. When I look at different research projects that we've done with University of Regina, for example, working on burnout scales, 29% pre-pandemic, 45% now, showing clinical signs of burnouts. That's not Linda Silas saying you look kind of tired right now, maybe take a day off or go crawl with a good book. That's clinical signs where they need clinical help. We don't even have enough clinical healthcare workers in mental health to help us. So we really have to do a collective work on what we're doing. The number one reason they're feeling burned out is 83% are saying insufficient staff. So that means every day they go to work, they finish their shift, and they feel they haven't done enough for their patients. They feel like they just haven't done enough. They feel they might have done errors. And what do we do from that? A few weeks ago, we had a meeting with the Minister of Health federally and the Minister of Seniors. And the best quote they had of that hour meeting with nursing leaders across the country was, if we can't take care of those who take care of us, we will fail. And that's what we have to all remember on this. So if I look here, Gail talked a bit about it, but we are a large workforce. 10% of all employees in Canada, workers in Canada, work in the care environment, work in healthcare. And we do spend a lot of money. Look at all the provincial budgets. It's, 40, 45 plus % of the provincial pie goes towards healthcare, 8% of GDP. If we would have this shortage in any other industry, I guarantee you there would be urgent commissions funded by every provincial, territorial, and federal government, because it'd be a crisis. But because it's healthcare, they're kind of playing soft. This is a workforce problem, so it's a supply and demand issue. And it's, as nurses, we often kind of confuse it with our professional responsibility. But that professional responsibility is what is burning us out. We need to talk about it as a supply and demand. And right now, the supply is not there to answer to the demand. So we're talking about solutions. Everyone is talking about the same thing. We need a pan-Canadian health human resource plan. Can it be a health human resource, a nursing resource? It doesn't matter, but we need to bring the experts together and have the proper data and look at the best practice across the world and fund these best practice. And that's how we're going to recommend it. And you're going to see many more organizations like the RSC Commission report to bring these recommendations. What I say is that we need a change in culture. We need to move away from the martyrs of healthcare. And that's what we've seen nurses, the martyrs of healthcare. Employers, governments, policymakers know that nurses are going to stay there. And it's like that elastic band. They'll stay, they'll stay, they'll stay. And right now they're breaking. We need to change the culture to see nurses and the rest of the team, but we're talking about nurses right now, as professional workers, and really respect them as workers and respect that they have a life. At the end of their shift, they need to go home, regardless as to take care of their kids or to go to the gym. They need to go home and they need that time. What we're starting to talk about is always retain. If you can't retain your workforce, you will never be able to recruit into it. But we've added a new R, is return, because so many nurses left the healthcare workforce, or as Gail was mentioning, those experts that are there that just want to help. We know that there's 35,000 vacant positions around. You need 1.5 bodies to fill those positions, because guess what? If I'm a full-time nurse, I might get sick, I'll need vacation, family leaves. So you need those part-timers and those casual to make it happen. And we only graduate 12,000 nurses in Canada. So I'm not very good in math, but it doesn't equate. So really, there's no magic bullet, but it will be about retain, return, and recruit. And in 7 minutes, I don't have time to go through all the strategies, but there are many. So I thank you, merci, and miigwech.
Thank you so much, Linda. And that is very, very informative. And, to your point, there's not enough time, and there's such an important topic. So I would like to go to Dr. McCarthy and to talk from an international perspective. And I also urge the panelists to have a look at the chat box. There are some great questions. We will be posing a few, but if you're able to respond to any, please feel free to do so as we are having the next presentation. Over to you, Carrie.
Thank you, Tara. I want to thank the Royal Society of Canada for having me into this important discussion, and also the Nova Scotia Health Authority for inviting me to participate today. So as Tara mentioned, I work at the World Health Organization, and so I'm happy to provide some global context for you when you're considering the recommendations of this report. And I think the global piece is important, not just from my perspective, just to see how well different national and regional pieces are responding and in line with the global directions, but also that seeing our alignment at the global level with what's happening in countries to make sure we are basing those on the experiences in country, and that we are informed by what's happening in the ground. So I was really appreciative of this report coming out. Right now, we're actually at the World Health Assembly is going on, and that's where all the member states of the World Health Organization come together and consider global health policies and strategies, and often endorse different strategies with resolutions that encourage all member states to advance certain strategies. So when we're talking about the global context of human resources for health, which include nurses and midwives, I just wanted to point out that we do have a number of strategies that have gone through this governance body of all the WHO member states and the health ministries of all the countries. And that is, we have a global strategy for all health workers through 2030. And that includes nurses and midwives, and has big pieces on the data, and just institutional capacity and performance, and working conditions of health workers. When that strategy was developed, they identified a predicted shortage of 18 million health workers needed to achieve some of these health-related goals in the Sustainable Development Agenda for 2030. So that huge gap in health workers was part of the reason that the UN, the former Secretary General of the UN, convened this high-level committee to look at how are we going to address that shortfall of health workers, and really looking at how we drive those investments in education and employment and working conditions of all health workers, so that we can overcome that shortage and be able to provide the services that populations desperately need for primary health care and universal health coverage, as well as others. Now, shortly after that, we had a big global campaign focused on nursing and midwifery for a few years that was also catalyzed at the World Health Assembly. We had the Year of the Nurse and the Midwife to stimulate investment and action in nurses and midwives. We had the very first State of the World's Nursing Report 2020 that gave us some of the best data and understanding about all the dimensions of the global nursing workforce, and a country profile for every country describing their national nursing workforce. We did the same thing with the UNFPA as lead for the State of the World's Midwifery Report. And these were all key pieces of evidence, the global level and the global policy level for nursing and midwifery, that then also catalyzed the current global strategy for nursing and midwifery, which also went to the World Health Assembly last year, which was the first time that the global strategy for nursing and midwifery had ever gone to the World Health Assembly. And it was adopted by all the health ministers with a resolution encouraging all member states, all partners, to advance the global strategy for nursing and midwifery. And that was the first resolution in 10 years on nursing and midwifery. So right now we have a really clear global mandate. We have tons of momentum around the global strategy for nursing and midwifery. So I want to give you a sense of what that is, and point out some of the key areas that are aligned with the report that we're discussing today. So these are the 12 policy priorities of the global strategic directions for nursing and midwifery, and they fall into these 4 policy areas of education, jobs, leadership, and service delivery. In each of those 4 areas, there's a 5-year goal, our strategic direction for each of those areas. And I won't go into too much detail on these, but I'll just mention that, like in the education area, we're focusing on those levels of education for nurses, and do they align with those optimal roles in service delivery settings. We want to make sure there are enough graduates, we've been talking about that a bit today, to meet health system demand. We want to make sure that education programs are competency-based and have quality standards like accreditation. And we want to make sure that the faculty, there are enough faculty and they're trained and supported to develop that next generation of nurses and midwives. And in jobs, the policy priorities are about a lot of things we're talking about today, that planning and forecasting for service delivery by nurses and midwives, making sure there are enough jobs for nurses and midwives, and making sure the health system is creating those jobs, reinforcing ethical migration, international recruitment and migration, and being able to develop, attract, recruit, and retain nurses and midwives where they're needed most. The third area is leadership. And there's 2 policy priorities in there in the global agenda, and that is establishing or strengthening that senior nursing midwifery leadership position at the national level and subnational level, and also investing in leadership development for nurses and midwives, so they have that policy knowledge and leadership skills in their repertoire. The last area is service delivery, and that falls into two areas. One of the policy priorities is about regulation, professional regulation, making sure that those are up to date and strengthen and enable full practice and full contributions of nurses and midwives in their service delivery settings. And the second one is really about the work environment. So enabling what needs to be in place to enable and support nurses and midwives in providing those services in a range of different settings. So when I kind of thought through looking through the recommendations of this great report and couldn't help mapping them to the different policy priorities. And Russell, I'm going to ask you just to click through a few times, but I really saw like recommendation 1 was clearly in that area of jobs, those 3 in red. Recommendation 2, oh, sorry, go back. Recommendation 2 was that work environment one over on the right. Also recommendation 5 and 6 from this report were really about that workplace environment to me. Your recommendation 3 about the policy engagement of nursing leaders at different levels was really aligned with that leadership piece, both that senior nursing leadership piece and that development piece and mentoring piece. And then your recommendation 4 was really about collaboration. I think mentioning in there was that regulation aspect with councils and supporting faculty and all these key aspects that really came out strongly in your report. Because there were at least 3 recommendations and sort of sprinkled throughout in this report that really focused on that work environment. And Linda, wow, really comprehensively described some of those key pieces in detail. I just wanted to point out that this one policy priority in the strategic directions does touch on that as well, to the extent that it's useful to have this global policy priority pointing out some of these issues as well. So it sort of gets at the what of workplace policies to enable that full service delivery and covers things like the enabling environments, but also gender discrimination, issues of diversity, inclusivity, and also making sure rights are protected and there's decent work. And some of the enabling actions that we encourage in the global strategy for nurses and midwifery have to do specifically with the impacts of the COVID pandemic on nurses and midwives, but also have to do very explicitly with the staffing and the allocation of nurses and midwives on those teams, enabling full practice and decision supports, and those issues of eliminating, having zero tolerance for any type of discrimination, violence, harassment, and also encouraging gender transformative policies. So these are all in the specific to nursing and midwifery for our strategic directions for the next 5 years. I wanted to also give you, just bring it out a little bit to health workers in general on this COVID impact. And I know that we've talked about a lot of these things today, but we are looking at this in the global level as well, and trying to get some of those global pieces of data that in the areas of not just the health of care workers, but their social and well-being, and really diving into that working condition and that working environment that we know is so important. And also the availability and distribution, and what some of those response mechanisms have meant for the availability of nurses and midwives. I won't go into more detail on this slide. I want to point out something that is still in the working conditions and working environment topic, something that's being discussed. Well, actually, they just adjourned a little bit ago, and we'll start again tomorrow. There is a report in front of the Health Assembly to look. It's called the Global Health and Care Worker Compact. It's a proposed compact that includes these 4 domains in terms of safeguarding the rights of health workers, ensuring inclusivity and freedom from discrimination, providing the supports, and preventing harm for care workers. So what this was actually requested by the previous Health Assembly for WHO to develop this and bring it back for consideration at this assembly for potential adoption with a resolution by all member state ministries of health. And what this is a compendium of existing legal and international instruments that can be used to inform policy, advocacy, and benchmarking, and moving forward on protections and safeguards for all health and care workers. So it'd be a really great resource for improving health worker environments and for advocacy at the global, national, regional level, what have you. So I wanted to point this out. Hopefully we'll have something decided on that by the World Health Assembly tomorrow. And I'm going to wrap up there. Looking forward to the future discussions with you all. Thanks so much.
Thank you so much, Carrie. And I'm just watching this all the amazing presentation, and equally amazing the comments and the chat in the chat box and the questions that are coming up. So I'm going to try and be very creative. I've tried to review all the questions. So I've combined them in a way that we can pick up 3 key themes, and I'll go to each of you. I've also decided that who I'm going to for each of the questions. So good luck with that. So I'm going to go, Linda, to you first. There's a lot of conversation on the flexibility and kind of thinking about the newer nurses and how their preference may be. So when we think about really valuing the nurses and bringing that to the work environment, so can you speak to what are we thinking when we say full-time, part-time, and how can people work in a way that really matches their lifestyle needs, thinking also about many women being nurses. So could you speak to that, please, Linda?
It's all about a balance, all about workload. It doesn't make sense when a nurse of any age tells you that he or she cannot work 37 hours a week. That's the average of a full-time job in Canada. And it's because we're understaffed, because we don't staff properly in the right areas, the right time, and we don't respect those individuals as workers, that they do have a life outside the work. I was looking at the list of questions, and Michael asked about funding, all these beautiful recommendations, and he's absolutely right. Nobody's committing to real dollars and cents to help the situation. Another of your comments asked, is it because we're a dominated female profession? I would say yes. It's been going on for way too long, and it's because of that YX chromosome and that we accept a lot of BS for way too long. Young nurses are telling us they want paid preceptorship. They know that if they have a solid orientation, they will remain in that job and they will remain happy. Our spicy nurses, our older nurses are telling us, respect my experience, put me as mentors, help me help those that need orientation, respect that experience. And I could go on, but it is about respecting the worker and making sure that we have enough of them. And sometimes it means closing services.
Thank you, Linda, and well said. And a lot of people are agreeing with you. And so please continue to watch and see if you can continue to respond. Carrie, I'm going to go to you. And, it came through your presentation quite clearly, and also with the audience questions, is that, so these are all not new. So how do we really hold the fire to the process? How do we get this to action point? Because we've been around this block before. So what would you suggest to that?
Yeah, I think I agree. When we were looking through the previous strategic directions for nursing midwifery, a lot of these key issues were coming through, and a lot of the global resources have really been kind of hammering on these similar themes. I think what's different now is that there has been a resolution at the global level. There is a strategy for nursing midwifery that's been adopted with the resolution and has that urging of member states and partners to include. So there's a lot of traction there that should it wish to be leveraged and actioned on. So I think there is an opportunity for that real policy action, for that political action and advocacy, and a lot of strong basis to do that. I think that needs to translate then to the country level and how countries are prioritizing development of their nursing midwifery workforce, or the health workforce overall, in order to achieve the health goals. And we know that means dealing with the working conditions and those challenges, because otherwise there's just not the health workers in the places they're needed to provide those services. So I think there is, on the one hand, there's larger challenges than we've probably ever seen. Linda said she's never seen it so bad, and I believe her. I think so that's on the one hand. I think the other hand, we have traction and political and advocacy support, and that we've never had before. And so I think it's a matter of what countries are able to identify, and then how partners different types of partners on the ground can support. And I think there's different ways that all of our agencies engage in different ways to advance those country level priorities. And so I think as WHO, we engage with our different partners, our collaborating centers, our non-state actors, our groups like ICN and ICM, to really engage at the country level. And I think it's a matter of really everyone coming from their respective roles and the contributions that they can make to take it forward in different country contexts.
Thank you, Carrie. And I'm going to go to you, Gail. So, one of the things, as we know, we have this fantastic report, as there have been many reports. So how do we hold ourselves to action? So what about the funding that is required to do additional work? So in your role, how are you seeing that through, like bringing all of these actions to place, and also thinking about many of these may play out in different ways in other jurisdictions. So how do we bring a common theme, and how do we work together nationally as well as we action them?
Thank you. Thanks so much, Tara. And this has been very, very helpful today. From our end, I'm looking at the comments, and they're so important. What's new? We've said these things before. We've had strategies. I've written and led up many of the reports and what have you. I think the difference now is that we have the system overall in this country and elsewhere is at a standstill. And Linda's talked about that we can't continue to, on the back of nurses and other providers, deliver care. We need to stop and think about, okay, do we need to slow down services? Do we do these things? And slowing down services, whether it's a surgical backlog or whatever, are all very political. So now we've got these strategies that are impacting the highest level political tables, as well as our decision makers, to figure out what are these strategies. Where we're making a difference across this country, I believe, is we're bringing solutions to the table. I see Annette Elliott-Rose, for instance, is answering some of these in the chat. There's many experts who've been around. Carol Estabrooks has made some comments, and others, that we need to be very careful. We've got strategies. There's not one strategy. We cannot, for instance, increase the numbers of educational seats without thinking about employment, deployment, appropriate utilization. For instance, we can't be thinking about hiring and assuming that people don't want full-time work, when indeed many do want full-time. Some do want part-time, some do want casual. But it's also investing in these strategies. These aren't just nice things to do. Annette has talked about innovative ideas. We have innovative grants, for instance. Some of the best investment in innovation is with our nurses and our health workforce at the point of care, who understand some of the innovations that are going to make a difference. So it's investing definitely in them. The last comment I will make, and I think it's over to Carrie, I've had the privilege of leading up a WHO PAHO Collaborating Center for many years. We've learned many lessons at the country level. Context matters. We need to engage people in a meaningful way. We need to build capacity. So that we need to take some of those lessons learned and apply them to many of our strategies. And they have to do with transitioning into practice. They have with supporting nurses and others on an ongoing learning journey, and to make their lives easy than what we have been. And that takes an investment. That means money. And if we don't invest in these strategies, we are going to continue to have the gap, and the care delivery system is not going to be adequate at all for Canadians or for others. So that's a lot I've counted into that answer.
Thank you so much, Gail. So I'm going to give maybe a minute or 30 seconds to each of you to say, what is the one thing that you're doing, either within your organization or jurisdiction, to bring in any of these things that people are talking about, or some action, the way forward. So I'll start with you, Linda, and then over to Carrie, and then to Gail.
Well, for us, we gave the message solid to all premiers of province and territories. We're hand in hand with them to put pressure on the federal government to get more transfer payment. The only caveat is we need to see a strategy on health human resource. We cannot continue on that. We're also working with the federal government to see if we can work under EI for bridging programs, because everyone is telling us they want to improve their future, but also look at better education, going from an LPN to an RN to an MP, or personal care worker to an LPN, or even an RN going for her critical care course. We need to link the programs that exist for other workers and make them available for nurses. Thanks.
Thank you, Linda. Carrie?
Sure, thanks. I think in terms of what our organization is doing, I think the most exciting pieces, in addition to the global strategy for nursing midwifery, is those things that are coming through the World Health Assembly right now. So encourage you to watch for that global care compact and how that can be leveraged in your settings, and And also something coming through the Assembly for Human Resources for Health is the Working for Health program, 2022 to 2030, hopefully taking us through the end of the SDG period. And this really gets at the investment issue that people have spoken about, which is really at the heart of it. If we're not investing in the education, employment, and working conditions, that we can't expect anything to change. And I think we're in a really tough period with this global economic downturn and with countries spending on health going down, and we really needed to at least stabilize or if not increase in terms of investments in these areas. So the Working for Health program is really focused on how to find that fiscal space nationally, how to engage partners, international financing institutions on driving that investment in the right direction. So I think that's another piece that we hopefully will make a difference from our end. Thanks.
Thank you, Carrie. Over to you, Gail.
Thank you, and thanks so much. And a couple of examples that I'm going to give. Number one, it's action. So for instance, we have done all of the training and certification, whether it's assessment for internationally educated nurses, critical care nurses, paramedics, doesn't matter. We've branded that differently. We now have, we believe in ongoing lifelong learning and supporting nurses and others to do that. So we have rebranded that part, which was interprofessional practice and learning, as a learning institute for health care providers. So this the focus is different, an ongoing learning journey. The second thing is I'm hearing both Linda and Carrie talk about wellness. So that within a health innovation hub, we are at this point developing thoughts around thoughts around a wellness institute, and a wellness institute where we actually focus on keeping our health workforce healthy. We've learned a lot of this from our workmen's comp colleagues who have worked really, really hard with us to get people well in a way that they can actually move into work. But we need to do more than that. And so this wellness type of institute is something that we're really excited about. So those are two examples I'd like to give as pretty concrete.
Thank you so much. And there's so much, and I feel like people can reach out to any of you, ask our additional questions as we are trying to wrap up the session. I would encourage that people do go and read the full report. It's available on the Royal Society of Canada's website. On behalf of Royal Society of Canada and myself, I want to thank the amazing panelists for sharing your expertise and experience today, but also to thank the audience for their fantastic participation through and through. And also I would encourage people to join the conversation on Twitter by following at RSC, the Academies. And if you have additional questions, you can email to events@rsc.src.ca. So recording will be available, absolutely yes. And thank you all so much for joining today. And thank you to the wonderful panelists, and thank you to Royal Society of Canada.